us for the first time. Global Outreach Consortium is an NGO that is based in Ghana. It's made up of dedicated professionals from both medical and non-medical backgrounds. And our mission is to improve access to medical care for the underprivileged and underserved communities. And we do this through collaboration and then also strategic partnerships as our foundation. And it's important to mention that although the Bisayen project started last year, January 2024, it was officially launched on the 11th of June 2024. So today is exactly 1 year since the project was officially launched. And the project is currently active in 3 regions of Ghana. That's the Ashanti region, the Greater Accra region, and the Northern region. The project is structured around 2 major pillars. The first one is hospital-based activations, where we work closely with healthcare facilities to ensure that patients and their families, patients with breast cancer and their families, receive a truly patient-centered experience during their breast cancer journey. Then the other leg is the community-based activities, which is aimed at improving and then knowledge regarding breast cancer, and also empowering the communities and also supporting them with the goal of realizing early detection and then destigmatization of breast cancer. A critical third pillar is the capacity building of healthcare professionals. And that is why we are embarking on these continuous professional development programs. And the aim of these CPDs is to equip healthcare providers with updated skills and knowledge in breast cancer diagnosis and management. Last week, we had a session on breast cancer in pregnancy and palliative care in breast cancer. And it was a great time. And I believe today we are also going to have a very good time based on the topics that we are going to treat this evening, and also the presenters who are going to give us these presentations. So on that note, thank you all once again for being part of the journey towards better breast cancer outcomes in Ghana. And at this juncture, I will hand over to the moderator for this evening's exciting program. And that is no less a person than Dr. Joseph Hansen, who is a consultant family physician and a mentor and a father figure to a lot of medical doctors in primary care and family medicine. So Dr. Hansen, I will hand over to you at this juncture to continue with the moderation. Thank you very much.
Okay, thank you very much, Dr. Amo. I'm also grateful to you and the consortium for giving me the privilege, to moderate this very important event. Breast cancer, I usually refer to it as a very treacherous disease. I'll briefly tell you about 2 cases. One of them, in her early 40s, was the daughter of a very experienced nurse. By the time they detected that the child had breast cancer, it was so advanced that within weeks, she was dead. This was in the US. The second was also in her early 40s, but she survived. Then there was a third one. She had just retired, and within a year, she was also dead from breast cancer. The advanced form of the disease is very frightening and normally poses both a challenge to the doctors, the caregivers, and the family. So we are very privileged to have two prominent doctors to discuss the management of these advanced stages. The first to speak to us will be Dr. Hannah Aite Ani, who is a consultant radiation and clinical oncologist at the National Radiotherapy, Oncology and Nuclear Medicine Center, Kolebu Teaching Hospital. She has over 2 decades of cumulative clinical and academic experience in oncology care with deep expertise in breast cancer care, palliative radiotherapy, and cancer control in low resource settings. Dr. Ani is the immediate past president of the Breast Society of Ghana and has been instrumental in advancing breast cancer management and awareness in Ghana and beyond through her clinical work, research, and policy advocacy. She has been involved in multiple international collaborations and research and has several peer-reviewed publications to her credit. She will speak to us today on current trends in the management of metastatic breast cancer. On this note, I would like to invite Dr. Ani to give her presentation. Thank you very much.
Thank you very much, Dr. Hansen. I will share my slides. I'm grateful for the kind words. Okay, so this is Hannah. Hello to everyone. I can leave my video off, right? Hello?
Yeah, yes, you can.
Okay. All right. Okay, so please let me know if you can see my slides.
Yes, we can.
All right, so I have 30 minutes. Okay, so current trends in the management of metastatic breast cancer. The outline of my presentation will look at the epidemiology of breast cancer. We'll look at the classification, what classifications we have in breast cancer, staging of breast cancer, and then some of the symptoms patients present with metastatic breast cancer. Then we'll look at the diagnosis of metastatic breast cancer. Where it becomes very technical is when we look at the management, systemic management, looking at the current trends that we have and the mechanism of action of these medications. Then we'll look at radiotherapy, what role radiotherapy has to play, and the principles of survivorship. So hopefully we'll all be able to take something away from this presentation. So if you look at the map of the world, Africa being in the center right in front of us and other parts of the world, you see it's all virtually pink. Breast cancer is the most common malignancy almost everywhere in the world, as you can see. So it's almost pink everywhere. You see some areas where it's a bit of orange, that is the cervical cancer and blue lung cancer. But if you look at the majority, it is actually breast cancer. So breast cancer is the leading cause of morbidity and mortality in women worldwide and remains a significant global health problem. Global statistics show that about 2.3 million breast cancer cases annually are diagnosed, and this number is projected to double by 2035. It accounts for more disability-adjusted life years lost. That is the burden of disease that reflects the amount of healthy life that is lost. In high-income countries where there is easy access to early detection, diagnosis, and treatment, the 5-year survival approaches 90%. That is, 90% of people diagnosed with breast cancer will be alive by 5 years and beyond. This is also possible from a study that I did about 6 or so years ago, where the 5-year survival rates approached 80 to 90% in patients who were diagnosed early and those who had non-metastatic disease, where the disease had not spread to other parts of the body. Cancer care in Africa has greatly improved over the last 10 or more years. However, incidence of breast cancer continues to rise steadily despite these advances in treatment and improving outcomes. In Ghana, approximately 5,000 cases are diagnosed each year, with about half of that dying from disease. Peak age of breast cancer diagnosis in Ghana is 40 to 49 years, so majority of our patients are within that year group. African women, like we all know, tend to have more aggressive types of cancer and are diagnosed in advanced stages. Metastatic breast cancer represents over 50%. In fact, it's not clear, it may be much more than that, probably between 50 to 70% of new cases seen at the clinic, which is alarming. I did a breast cancer study in 2017, my dissertation, and what we noticed was that out of about 2,000 or so folders we looked at, my study sample was 300 so, and that was the amount of, for breast cancer patients who did not have metastatic, they were either early or locally advanced disease. For majority of them, excluding the 300 that I got as my inclusion criteria, those who fitted the inclusion criteria, and those who were a minority who were not within the study inclusion criteria, almost all of them, the rest of them, that is about 1,500 or so, were metastatic. So you can imagine this was a period over 10 years that I actually studied. So late presentation is a major contributory factor for this. In Ghana, if you look at the number of new cases, we have about 27,385. That was Globocon 2022. And number of deaths, 17,000, which is even more than half that amount. And as of the prevalent 5-year cases we have, is about 63,764. If you look at this other figure from Globocon, you realize that you see breast cancer is right on top, with prostate cancer also following immediately beneath that, and then cancer of the uterus. So it's the same. For incidence and mortality, male and female is still breast cancer. The top 5 most frequent cancers, you look at the far left for males, you realize for males it's liver followed by prostate. For females, which is in the middle, you have breast cancer followed by cervical cancer. Then if you look at the far right, apart from the others, which is several cancers put together, so you can't say that is the largest because there are so many other minor rare cancers or minority of cancers. Breast cancer is number 1 with both sexes, followed by liver cancer, cervical cancer, prostate, and Hodgkin's lymphoma. Also, looking here, you realize that the incidence of breast cancer in 2022 was about 31% and mortality about 24%. This is a diagrammatic representation of the cases seen at the National Radiotherapy, Oncology and Nuclear Medicine Center in 2023. The topmost graph you see is that of breast cancer, and this was telling you the trajectory from January all the way to December in 2023. You can see that except for a small dip somewhere in August, there was a fair rise in the cases. Then followed by prostate cancer, other types of head and neck cancer, cervical cancer, and colorectal renal cancers. Then this is the top 10 cases in 2024. As you can see, breast, prostate, head and neck, cervix, etc. Breast is at the top. So from January all the way down, breast cancer topped in the number of cases that was seen in the month, totaling 758 new cases of breast cancer seen at the Radiotherapy Center in Kolebu by the end of 2024, December last year. Total number of new cases, 2,628. When I joined the center in 2005, we had about 700 new cases at the end of the year. In 2005, that was the number of cases, new cases we see of all cancers, 700. That alone is the number of breast cancer cases we are seeing in 2024. And now the total number of cases is 2,620. That's about 3 times the number we saw in 2005. And this was 28.8%, almost 29% of all the cases seen was breast cancer. So what are the classification of breast cancers? It's important to see this because we'll realize as we manage them that these classifications are important. First of all, you can look at it from the histology point of view where we have ductal carcinoma, lobular carcinoma, medullary. So there are various types. Breast cancer is not just one disease. There are different types and their management or their prognosis may differ. Some of them have a better prognosis than others. Then from the site, whether it is invasive, it's gone beyond the basement membrane, or it's non-invasive, very early, or it is metastatic, which we are going to be talking a lot about. And then on the far right, the molecular markers. There are some molecular classifications which were done. Previously, it was just everything breast cancer. But then it got to a point we realized that there were various types of breast cancer, some molecular markers which differed among breast cancers. And now the management follows the line of those molecular markers. So we have patients who come in who are hormone receptor, HR is hormone receptor positive. And then those that is they are either estrogen or progesterone receptor positive. These receptors are found on the cancers. Or those who are HER2, that is human epidermal receptors on the 2 type on the cancers. You understand more of this as we go on. So those who usually have hormone receptor positive, HER2 negative, they tend to be luminal A, and they have a better prognosis than the others. Then those who are luminal A, they are hormone receptor positive, but they tend to be HER2 positive. So they are more aggressive than the luminal A cancers. Then you have the HER2 enriched, those that are purely HER2 positive. They are also fairly aggressive. Then the triple negative breast cancers, where you have hormone receptor negative and they are HER2 negative. So they don't have any receptor at all. They are also very aggressive cancers. And amongst these triple negative, we have various types. There's the basal-like type 1, basal-like 2, immunomodulatory, and all of them have the various characteristics. So if you look at it closely, this gives you an idea of the further classification of the luminal A, estrogen, progesterone positive, and the Ki67. Ki67, you see a lot on the immunohistochemistry reports that come. They are usually, it tells the proliferative index, how much or what the extent of proliferation is, how fast is the tumor growing. Usually that's what the Ki67 is saying. So as you can see, luminal A is fairly low, the proliferative index. And then in the normal breast-like type, fairly low. But in luminal B, HER2 enriched and basal-like, it's high. So what about the staging of breast cancer? The current staging system is the 8th edition, the AJCC cancer staging. And we all know about the tumor node metastasis, TNM. So usually we'll look at the stage. We won't go through all of it, but just to give you an idea that we have various, the staging system, which is absolutely important. So the tumor size, T1 less than 2 centimeters, T2 between 2 to 5, T3, etc., and then T4, where it's involving the chest wall or the skin. Then we also have the nodal staging, which also gives us an idea of the stage of the node, depending on the number of nodes or the group of nodes which are also which we identify either clinically or after pathologic examination. Then the M, where is the metastasis? So M0 is usually where there's no clinical radiographic evidence of metastasis, and M1, there's distant metastasis. So what we are discussing today are those who have M1 disease. So if you look at this staging here, you realize that we have the stage 0, 1A, 1B, 2A, 3B, 2B, then as it goes, so these are earlier, then we get to 3A, 3B, 3C, which are more advanced disease, then stage 4, IV down there. So any stage T, and there are some people who can come in with maybe a T1, T1A, T1B, T1C, that is fairly early T stage, and then an N, any N. The person may come in with N0 or N1 or so, but with M1. That means that even though it seems like the disease came in early, the T is early N, we still have found metastatic disease there, where M1. And metastatic disease is where the disease is anywhere outside the body, immediately where, I mean, the breast and the local regional area, that is the lymph nodes and immediate surroundings. Immediately it moves to the brain, like you can see in this picture, depicting the disease in the lady's brain, or in her lungs, or in the bone. These are the common sites of metastasis, or into the liver. Then you know the patient has brain metastasis, metastatic disease. So what are some of the general symptoms a patient who has metastatic disease will come with? They may come with fatigue. They are tired, easily tired, and they may not be able to understand why. They may have poor appetite. They are not able to eat well. They are losing weight. In spite of whatever they are even able to eat, they may become cachectic and all of that. What are some of the sets? So those are the general symptoms. Then the specific symptoms. If the disease is in the brain, patient may come with headaches, vision problems. They may have personality behavioral changes. Sometimes they may have been referred to the psychiatric unit because they were behaving abnormally at home, only for CT scan to show that it's actually a brain metastasis from cancer. If it's involving the lung, if it's in the liver, they may be jaundiced. They may even become with bleeding, symptoms of bleeding, and it may point to liver disease. Or in severe cases where they are getting to liver failure, they may come in pre-comatose state. Bone metastasis, they may come with pain in their bone, in their ribs, in their hip, wherever the bone metastasis, even in the scalp, where sometimes the bone of the scalp, there's disease there, and you may see weak areas and bumps in the scalp. They may also come with fractures. A number of times our patients have come in, the first time they presented was when there was a fracture. They may have noticed a lump in the breast, which may not even have become ulcerated or so, but they just ignored it. And then next time they may come with a fracture, go to the orthopedic surgeon, be managed, only to find out that it was actually cancer that had metastasized. Then lymph nodes, they may also come with swellings in the armpits and the other side, in the other breast, in the armpit of the other breast, which will be termed metastatic. So this is another description. For the brain metastasis, they may also come with frequent falls, where they may also probably be falling, unexplained falls, or seizures. And this may be something you also need to look out for. So to diagnose metastatic breast cancer usually starts from the clinical, the history and the clinical examination. Some patients may already have been known to have breast cancer. They've been treated for early breast cancer or locally advanced breast cancer, so the doctors know them. They are now on maybe tamoxifen for 5 years or Arimidex, and then suddenly they start developing symptoms. So they are not new patients, but we have those who are de novo metastatic breast cancer, those who are now coming in for the first time. The first time they came, they had brain metastasis, they had liver mets or so. So at that time, there's been no test that has been done to diagnose breast cancer. So in these cases, you may have to do a biopsy. There are even patients who may have had an initial lump in the breast, but that has disappeared. The immune system may have got rid of that, but they ended up having disease spreading to other parts. So you have to do a biopsy, and then you do what we call the immunohistochemistry. You look at the estrogen status, the progesterone status on the tumor, the HER2, as we discussed before, KRC7. Then you do imaging. Any type of imaging, chest x-ray to look at the lungs. If you can do a CT scan, that may even be better. Abdominal ultrasound, you want to look at the liver, is there disease there? Or a CT scan or MRI. And CT scan usually delineates better the bony structures or and the lymph nodes. And so MRI gives you a better soft tissue definition. And then a PET scan which can also, now we have a PET scan available in Ghana, the Sweden Ghana Medical Center. Then you look at the performance status, which is very important. Apart from the fact that you know the patient, you've taken the history, examination, done investigations, how strong is that patient? How well is the patient to withstand the treatment? Sometimes we forget that, but that is a very important thing. Then other biomarkers, because we are looking at the current trends in management. There are so many biomarkers we are looking which go beyond the estrogen, progesterone, and other tests. There's something we call ESR1. And usually it's people who have been on some form of hormonal therapy, tamoxifen, arimidex, or letrozole, or mistake, whichever type. And after some time, initially they were responding. Then it got to a point they did not respond anymore. So usually these patients may have developed what we call the ESR1 mutation. So this is a test that should be done. There are other tests like PIK3CA, AKT1, PTEN, and these are all new biological markers which are coming up, which the tumor will express. And when they are found to be positive, then you can give medications to target them. So what is the performance score we're talking about? We have the Eastern Cooperative Oncology Group, ECOG, which we use. There's also the Karnofsky score. The ECOG we use, they are different, 0 to 1. 0 is where they are fully active, able to carry on all pre-disease performance without restriction. Then 1, they are restricted. So when the doctor says you are ECOG 0, it means you are fully active, there's no problem. ECOG 1, where they are restricted in physical strenuous activity, but they are still able to go about doing their light sedentary work. They are ECOG 1. If they are ECOG 2, they are ambulatory and capable of all self-care, but unable to carry out any work activities. So they can look after themselves, but they can't do any other activity, be it light or not. And up to about 50% of waking hours, they usually are able to go up and about more than 50%. But for ECOG 3, they are capable of only limited self-care. Even the self-care is very limited. So they may be able to maybe help themselves have a bath, but at a certain point, somebody has to help them continue, or someone has to help them with some things they need to do. They can do a little for themselves. ECOG 4, they are completely disabled, cannot carry out any self-care, totally confined to bed or chair, and ECOG 5 patient is dead. So these are the scores we use. So we realize that the staging and all of that, the diagnostics and all, you can't move forward if you don't know the ECOG score of the patient. This is just to give an idea of the important things that the clinical breast exam, breast imaging modalities and biopsies which need to be done, and the role of the X-rays, the radiology, and nuclear medicine in staging. So what goes into the systemic management of breast cancer? So in the birth overview, patients who come in with newly diagnosed or recurrent metastatic breast cancer, you're going to do the biopsy, you're going to look at the biomarkers. I've mentioned a lot of them already. Then you determine the classification of the cancer. So if the patient does not have any of the markers, it's triple negative, what is the line of treatment? We'll look at further details later. If the patient has estrogen positive, HER2 negative, or they are HER2 positive, what is the treatment? So you see, it's not just one bracket, one size fits all kind of. You determine the classification and then you manage the patient accordingly. So starting first with those who are estrogen positive and HER2 negative metastatic breast cancer, usually the first line of treatment, if they are postmenopausal, most of the time, if they are premenopausal, the management line may differ slightly depending on the hormonal therapy agents you will give them. And you can actually even render a patient postmenopausal to be able to get some. So sometimes we have that discussion where the treatments are such that we want to give something like an aromatase inhibitor, where you need the patient to be postmenopausal. We can discuss that. You can either do surgery to remove the ovaries, do a oophorectomy, or you can radiate the ovaries to make them stop functioning as functional ovaries, or you can give them a drug like Zoladex, which will temporarily put the patient in a menopause state. Then after they finished the treatments and it stopped, then their cycles can restart. So the first line you're looking at in cases where patient may be postmenopausal with a hormone receptor positive disease, HER2 negative. You want to treat them with what we call the aromatase inhibitors. If they have not had that, then you do aromatase inhibitors, which is Arimidex, any of Arimidex or Letrozole. They are all aromatase inhibitors, plus new agents we call CD46 inhibitors. I will show you the mechanism of action of those to understand how these medications actually work. If you have already given aromatase inhibitors and patients progresses beyond that, then there's another drug we can give, which is called fulvestrant, plus the CDK4/6 inhibitors. And this fulvestrant, they are selective estrogen receptor down regulators. So you notice that everybody knows about tamoxifen. Tamoxifen are what we call the SERM. They are the selective estrogen receptor modulators. And then we have the down regulators, and one of them is fulvestrant. So they are also, it's not just about tamoxifen and Arimidex. These are all hormonal forms of treatment which are used in the management of hormone receptor positive breast cancer, which does not have a HER2 receptor, so HER2 negative. If you've given this and the patient does not respond, there are other tests you can do. Some of the ones I showed you, like the PIK3CA1 and the ESR1 mutations. Now, the current trend is you look at those as well for these hormone receptor positive patients, and then you give them drugs. So if they happen to be PIK3CA mutations, which you will find when you do some form of genetic sequencing, you can then put them on tamoxifen, aromatase inhibitors, or in addition add a drug which is called alpelisib, which targets this particular mutation. If they happen to also have the ESR1 mutation, that means that they are no more responding to the hormonal agents given. They've got this mutation. So then beyond that, it doesn't matter how much tamoxifen, Arimidex you give, they won't respond again. There are new medications that you can give, elacestrant you can give in combination with some of the other hormonal agents, fulvestrant, tamoxifen, or other. This also happens in the other case. If the patient happens to also have a germline mutation, you do BRCA. You all know about the breast cancer gene test. We have BRCA1, BRCA2. If they happen to be germline mutated BRCA, then there are certain medications which are called PARP inhibitors, which you can actually give to the patient. These parts can really be very complex, but it's important just to give you an idea that there are so many other targets we are looking, and breast cancer treatment is more precision oncology now. It's personalized. So you don't treat every patient the same way. Depending on the molecular targets, you treat patients accordingly. So looking again at the ER positive, just to give you an idea, there's something we call visceral crisis. And visceral crisis is usually a medical condition which is characterized by severe organ dysfunction resulting from rapid progression of the disease. So you usually see this by the signs and symptoms. The patient comes in, the laboratory findings, and how swift the worsening of the patient's condition happens. So when patient is known to have this visceral crisis, even though they are estrogen receptor positive, that they are hormone receptor positive and HER2 negative, you still would give them chemotherapy, because you realize the disease is progressing quickly. So you won't say, I'm putting them on because they are hormone receptor, I'm going to give Arimidex. If they have the visceral crisis like I've defined, you give them chemotherapy. If not, you give them any of the endocrine therapies with the CDK4/6 inhibitors, like I mentioned. If the disease progresses, then you look for the mutations. What we do is what's called a next generation sequencing, which helps you to find out what kind of mutation the breast cancer. And it's interesting, if you've seen such a panel, you realize patients can have so many mutations, because by the time a breast cancer develops, there are so many accumulation of mutations that can happen. And what now you are targeting is, what is the driver mutation? What is actually driving the disease now? And how can you target that? So if there's progressive disease beyond giving the endocrine therapy and the CDK4/6 inhibitor, examples of which we have palbociclib, ribociclib. So those are new medications. They have been around for a long time, but they are now becoming more available in our parts of the world. If patient has had that and they progress, then you go on to, and there's really no risk of organ failure, then you can give what I said, the SED, which is like fulvestrant plus that combination, or some other medication which is called everolimus, which is targeting another target called mTOR. So you see that there are so many different targets. Then you can also target the PIK3CA1, you can target the ESR1, or you can target the BRCA. If they happen to be BRCA, you've done the BRCA test and they are positive, then you could also target that. If they progress beyond all of these endocrine therapies, then you can give them chemotherapy, even if they are not in a visceral crisis. So this is just to show you the visceral crisis I was talking about. So beyond endocrine therapy for the hormone receptor positive patients, where you need to come in with systemic therapy, there are a number of preferred regimens we all know about. Some of them we all know. We have the anthracyclines. And the common drug, there is doxorubicin that we all know about, or liposomal doxorubicin, which is a molecular form of the doxorubicin. And then we have the taxanes. A common type, we have paclitaxel, we have docetaxel. Then we have capecitabine. We've all heard about Xeloda. They are the anti-metabolites. So you see, these are a group of drugs which do specific things. Then we have capecitabine and gemcitabine, which are all type of anti-metabolites. Then we have the microtubule inhibitors, and like vinorelbine, eribulin. And these are all cancer medications. The chemotherapy medications work at various points of the cell cycle to stop the cell from growing. And other recommended regimens which we can give. So just to give you an idea, so this is an example of the cell cycle we have. And you can see that we have the G1 phase, we know the G1, the growth phase, we have the DNA synthetic phase, then we have the G2 phase where there's double check repair, and the mitotic phase where there's actually the cell division taking place. So you see in the colors here, you can notice the cell cycle, those drugs that are actually dependent on the cell cycle. Dactinomycin is a drug that works within G1. You have the DNA synthetic phase. Now you have the anti-metabolite. They are the ones that work to stop the DNA synthesis from taking place, like 5-FU that we all know, methotrexate. These are common drugs. The others, a lot of people may not know about. Then we have the drugs which work to stop the DNA synthesis, the G2 phase, the topoisomerase ones, like a toposide, a topotecan, irinotecan. There are other drugs that do that. And drugs that stop the G2 phase, like bleomycin. And then the mitotic phase. So the taxanes, Taxol, paclitaxel, docetaxel, they work to stop the mitotic phase from happening. Then you also have the cell cycle independent drugs like the anthracyclines, the doxorubicin, and the other medications. Then I mentioned CDK4/6 inhibitors. What are these? These are medications. You know, in the cycle, in the cell cycle, you have the cyclin-dependent kinases, which help move one area, progress from one type to the G phase or the S phase or the M phase, etc. These CDK4/6 inhibitors inhibit those cyclin-dependent kinases, so moving through the cell cycle. So that is how these drugs, palbociclib, ribociclib, and etc. act. So if you look at it closely on this one, you see the G1 phase into there's a G1S checkpoint into the S phase, the synthetic phase, from the growth G1 to synthetic. You notice that this cyclin D and CDK4/6 works to make sure that this phase is working appropriately as it is. The CDK4/6 inhibitor is stopping this, in essence, stopping the progression through the cell cycle and stopping the cancer from growing. So now we finish with the hormone receptor positive, looking at the HER2 positive metastatic breast cancer and second line management. In this case,
Dr. Annie, 5 minutes more.
Cancers, we start with all patients who are. It will depend on whether we can give chemotherapy, is it indicated or contraindicated. You've all heard about Herceptin, trastuzumab. Herceptin is an important drug. That's the same as trastuzumab. Now, the recommendation is to give trastuzumab together with pertuzumab, and these act on the cell membrane to prevent to prevent progression of disease. Then, if they don't respond to that, there are other second-line medications you can give. After you're giving trastuzumab, pertuzumab, there are other drugs. Now, they've even combined trastuzumab with chemotherapy. So we have trastuzumab deruxtecan, which is trastuzumab plus a chemotherapy agent, which is a deruxtecan, and they work together to prevent that. Then we have TDM1, which is also further trastuzumab plus the DM1, which is a chemotherapy drug. So they have these drug conjugates with a Herceptin to be able to be able to control the disease. The same thing, if they don't work beyond the second line, we go on to third line drugs, even involving some of the chemotherapy agents plus more Herceptin-based drugs or trastuzumab-based medications to work. So this is just giving you an idea. As you can see at the very top, that is where you have the cell membrane. So these drugs, the trastuzumab, they couple to prevent progression into the cell cycle. So from the cell membrane into the cytoplasm, and then that is the nucleus. So the nucleus is where you have the DNA synthesis happening. So if you're able to stop it from the cell membrane, you won't get progression through the cytoplasm into the nucleus to stop the cell from growing. So these are how the targeted therapies actually work. The last one is the metastatic triple negative breast cancer, where they don't have any of the receptors at all. Now, we've all heard about immunotherapy. They are the immune checkpoint inhibitors, PD-L1, PD-1, and all of that. They are those ones which have been tested and over time in clinical trials to find out how they respond to triple negative. And it's been found that because this group of cancers did not have anything like Herceptin to target A2 or Arimidex or something to target a hormone receptor. So there was really nothing, and patients were poorly managed. But now they can, if you target some of this like PD-L1, if you do that and patients are positive, you can give them some of the immune therapy agents as well. Even also if they happen to do the BRCA test and they are positive, you can also give them PARP inhibitors. So these are some of the ways we determine how to manage these patients. This is just to show you the immune system and how it acts in immunotherapy. So some patients sometimes present with oligometastatic disease. That is, they just have maybe very few, 1 or 2 or 3 metastatic lesions. Sometimes you are not sure. Looks like there's one lesion in the liver or one in the lung. Is it really metastatic disease? Is it not? So it's important to have MDT discussion to determine this and have informed discussion with the patient, aligning expectations of what the treatment is going to be. Consider the site of the metastasis, where that site is. Is it the CNS, is it bone, is it visceral, in the lung or liver, etc. Then what is the management of the primary? If it's just one, is it a disease that you think we can manage, and control the metastatic disease and also treat the primary disease? So these are decisions, very difficult decisions and expert decisions that have to be taken by the multidisciplinary team. Sometimes you may have to even bring in a local therapy. And there are cases where there may be one metastatic lesion. If there's evidence that there's no disease elsewhere in the body, you could actually treat that and then control the primary disease, and patients would have a long survival following that. Another important thing to mention after the as part of treatment is bone disease. When patients come in with bone disease, there are usually also some medications we give, and denosumab, zoledronic acid, which we give to help control this and pull the calcium back into the bone to strengthen the patients. So what role, briefly, does radiotherapy also have to play? Radiotherapy plays a very significant role in the management of metastatic breast cancer. It is not curative, but can effectively manage, can improve the quality of life, some cases even improve survival, progression-free survival, the patient, can cause shrinkage of tumors. Sometimes you have huge tumors, radiotherapy can shrink in it. Patient may be bleeding, radiotherapy will stop the bleeding. A lot of doctors, sometimes some of you may have referred to us with patients who are bleeding. can stop the bleeding or relieve obstruction. There's tumor which is obstructing some part of it. That could also be relieved by radiotherapy. We also manage bone fractures with radiotherapy, and then spinal cord compression. When the patient, there's risk of them becoming paralyzed or so, we can also treat with radiotherapy to improve mobility for them. So this is just an example of some of the plans we do. We'll do a CT scan, put it in a machine, treatment planning machine, etc., to be able to actually come out with a plan and then put the patient on the radiotherapy machine. This is an example of the patient setup with a linear accelerator ready to be treated. So before I end, there's some important information we need to know concerning survivorship. Principles of survivorship for patients who are actually living with metastatic breast cancer. It is a multifaceted approach. It's very important to encourage patients to promptly report any new or worsening symptoms, because they've come to you, you know they have metastatic disease, and there's invariably sometimes the disease may be in the liver, it will spread to the lung, to spread to the liver. There are patients who are living with disease in almost every other part, visceral, bone, brain, everywhere. It may start from one place, or if the symptoms worsen, your evaluation should be comprehensive when the patient comes in. If they come in with difficulty breathing, you won't just check the lungs, you will check the liver, you check the brain, depending on the symptoms they present with. So you won't just go doing any test, but you will do it from your history and your examination, you do the appropriate test. Then patients are encouraged to maintain a therapeutic relationship with their primary care physician throughout their lifetime. Because they are living with metastatic disease, they need to know, their doctors, primary care physicians need to know that and immediately intervene or refer them to the oncologist when the need arises. You need regular follow-up discussions about goals of care. Importantly, patient needs to have that discussion with you, because sometimes they leave thinking that the disease, whatever treatment you are giving, is actually going to cure them, which is not the case. So you need to actually have that discussion, engaging in patients in these discussions, even when you need to end treatment for some reason and do supportive care only. You actually need to have that discussion, and this also needs to align with their values. Surveillance and follow-up plans are very important, should be individualized to the patient. Even the management is individualized. So is the same for survivorship. Patients should receive MDT, multidisciplinary care, and it should be coordinated between the primary care physician, their specialists. There should be that continuity. People should have, all doctors in their care should understand what is happening. Otherwise, if the complication happens, they suddenly get a pleural effusion when they are not seeing their specialist. The primary care physician doesn't know about it. They are treating for pneumonia, but patient has pleural because they have breast cancer. Address all treatment options at each progression with the patient. Sometimes you may need to move to supportive care or hospice care, where you have to explain to the patient and relative that at this point, it is not beneficial for you to continue with the treatment. Early involvement of the palliative care team is absolutely important, so that you plan the care together, treatment goals, and psychosocial support. Some of the symptoms patients can come in, they can come with cognitive dysfunction, peripheral neuropathy, where they complain of anansi, other things like that, cancer-related pain, fatigue, cancer-related infections, chemotherapy-induced complications, or even the new agent, the immunotherapy. There are so many. Sometimes they could come with a bad pneumonia because of, or pneumonitis, because of the immunotherapy agents they are taking. So these are important. Then, lastly, the cardiac monitoring of patients who are taking medications is also important, because especially for metastatic breast cancer, they tend to be on, like you saw, first line, second line, third line. Every time they progress, we move on to another. So they may take many more medications than patients who came in with early breast cancer. So you need to follow them up very well. Their wellness and psychosocial support is very important. Screen them for anxiety, fear of progression, depression, and lead them to the psychologist where they also need that. You need to be consistent and clear with communication of such patients. So in conclusion, majority of our patients present with metastatic breast cancer. The trend is gradually changing. People are beginning to hear more about breast cancer and presenting earlier. but we still are with a lot of patients presenting with metastatic breast cancer. Proper stage and evaluation is very essential. Performance status determination, because you can't be giving chemotherapy to a patient who is ECOG 3. Beyond ECOG 2, ECOG 3, ECOG 4, you don't do any definite treatment. You just manage the symptoms patient comes with. Clear communication of management plan with the patient. What are the goals of treatment? They need to understand that from the goal. Treatment benefits as against the side effect. If your treatment is going to worsen their quality of life, then you don't do that. They may be better off with supportive care. Early incorporation of palliative care in the management plan. Their lifestyle, wellness, and psychosocial care important. Supportive treatment where necessary. Survivorship care plan is of the essence. Thank you very much.
Thank you very much, Dr. Annie. This has been a very detailed and also very technical presentation. I believe that there will be many questions for you, but we want to reserve the questions until we finish with the second speaker. So please post your questions to the Q&A box. We would want to go straight away to the second speaker so that we can discuss both together. Our second speaker is Dr. Abdul Jalil Inusa. He's a senior physician specialist and nephrologist at the Kolebu Teaching Hospital. He also has an MPH from the University of Ghana, an MPhil in nephrology from Stellenbosch University, South Africa. Dr. Inusa is also a member of several globally renowned organizations, such as the African Association of Nephrology, South African Nephrology Society, and the American Society of Nephrology. His clinical and research interests include HIV-associated kidney diseases, chronic kidney disease, predictors of contrast-associated acute kidney injury, and renal complications in cancer patients. And he has several peer-reviewed publications as part of his scholarly works. We are privileged indeed to have Dr. Inusa giving us a presentation on preserving kidney function during chemotherapy. Dr. Inusa, you can go ahead, please.
Okay, thanks very much, Dr. Hansen, for the kind introduction. Good afternoon, colleagues. I'm quite privileged to be invited to give this talk. As you can imagine, nephrologists are gradually creeping into the chemotherapy and oncology space, and I've been invited to present on how we can preserve kidney function during chemotherapy. I hope my slides can be seen.
Yes, please.
Yes, okay. So I have very few objectives here. I'll look at an overview of anti-cancer agents, nephrotoxicity, look at the preventive methods for nephrotoxicity in anti-cancer agents, as well as how we would manage nephrotoxicity due to anti-cancer agents. I must say that Dr. Ayite Ani has done a great presentation about all the various forms of chemotherapy and then their mechanisms of action. So that should help me in my presentation as well. So as presented earlier on, there's a rising burden of cancers worldwide, and Ghana is no exception. And this is rarely due to rapid advancement in oncology over the past few decades. There are new medications coming in, including immunotherapy and targeted therapies. And so therefore, cancers that were previously thought to be fatal are now manageable. And so we have a lot of cancer patients now developing chronic diseases as a result of improved management. However, despite these therapeutic advancements, quite a number of these medications also result in negative adverse outcomes, and some would include kidney diseases, which would actually impact the morbidity and mortality amongst these patients. It is therefore very important that we understand the role of these medications. In as much as they control cancers, we also look at the adverse events and see how we can balance them in terms of improving our patient outcomes. It's important to realize the strong connection between cancers and kidney disease. Generally, patients with cancers are at an increased risk of developing chronic kidney disease, and these actually arise either from the cancer itself or as a consequence of the therapies, as I alluded to earlier on. On the other hand, patients with chronic kidney disease or acute kidney injury also have an increased risk of cancers as well as impact the management of cancer patients. Generally, for patients with underlying chronic kidney disease, we may shy away from certain medications which would probably be optimal in terms of cancer cure. However, due to the renal impairment, we tend to have underdosing or using alternative suboptimal medications, and these may not necessarily augur well in terms of cancer cure. This intricate association or relationship between cancers and kidney disease has led to the development of a field of nephrology referred to as onconephrology. And this looks at the various kidney diseases that occur in cancer patients, as well as the impact of kidney diseases on cancer patients, and also look at how best we can manage kidney problems in patients with cancer. So it is a field that is rapidly developing, and then there's an increasing or tighter link between nephrologists, oncologists, and all the other clinicians involved in the cancer space. So why are the kidneys susceptible to nephrotoxicity? As we are all aware, about 25% of the cardiac output flows to the kidneys. Therefore, any drug in the blood will eventually reach the kidneys. And because of the kidneys' role in metabolism, as well as filtering and secretion of some of these medications, there's bound to be a potential of nephrotoxicity from some of these medications, particularly those that are inherently nephrotoxic. Mechanisms of kidney injury could include direct toxicity from either the drug or its metabolites, as well as obstruction of renal tubules and alteration of renal blood flow in the patient. Several factors may contribute to development of kidney dysfunction among the patients, and they include drug-related factors as well as the patient-related factors. Drug-related factors include things like innate toxicity of a drug, and from all the discussions, we realized that certain medications have a potential of causing nephrotoxicity, as well as their metabolites. Again, larger doses and extended duration of use of some of these medications may also increase a patient's risk of developing kidney disease. Apart from the drug-related factors, patient-related factors such as pre-existing renal impairment or CKD, such that patients with lower GFRs may be at risk of developing nephrotoxicity from some of these medications. The use of other medications with potential nephrotoxicity may actually interact with these chemotherapeutic agents and also increase the patient's risk of developing nephrotoxicity. And generally, as you age, your risk of most chronic diseases and complications from medications also increase. Presence of comorbidities such as diabetes and hypertension, which in themselves are risk factors for development of kidney disease, also compounds the nephrotoxicity of our chemotherapeutic agents. Also important is the volume status, and hypovolemia is a notable risk factor because of increasing drug concentration due to the relative low blood volumes. And so therefore, hypovolemia, it's always a target for prevention of nephrotoxicity from chemotherapeutic agents. There's a wide scope of diseases or presentations in cancer patients, and that would include things like acute kidney injury, which is the commonest presentation of renal impairment or renal dysfunction in our patients with malignancies. In addition to acute kidney injury, you have things like chronic kidney disease, usually from prolonged use of such therapies. And as I mentioned, the increasing survival of patients with cancers actually lead them to development of other chronic diseases, which in themselves are risk factors for development of chronic kidney disease. Additionally, certain medications may result in the development of hypertension, proteinuria, as well as electrolyte imbalances. These patterns of kidney disease could actually be pre-existing even before the development of a cancer or the use of any medications. Additionally, you may have cancer-related kidney diseases as well as therapy-related kidney diseases. So a quick look at acute kidney injury in patients with cancer. It's quite common to have acute kidney injury in patients with cancer, and this is usually associated with higher mortality risk, greater hospital stay, as well as inferior outcomes. And in this study that's depicted here among some patients in Denmark, there was an 18% risk of developing acute kidney injury within the first year of diagnosis of a cancer, and as high as a 27% risk of developing acute kidney injury within the first 5 years of cancer diagnosis. And generally, as many as 40% of critically ill patients with cancer may require dialysis, particularly those who are admitted to the ICU. It's always very important to realize that AKI development in any patient is a risk for development of CKD. And most patients with repeated episodes of acute kidney injury may eventually develop CKD. And this highlights the fact that as cancer patients survive for long, then there's an increased burden of chronic kidney disease due to all other adverse effects or adverse risk factors. It's also important to remember that any particular patient may have multiple risks for development of acute kidney injury. And therefore, in a workup for any patient with acute kidney injury, we need to look at our usual schema of determining whether this is pre-renal, intrarenal, and post-renal. And this has actually been depicted in the diagram to the right. It's also important to remember that the estimation of GFR relies on serum creatinine. And for most of our patients with kidney cancers, particularly those with advanced cancers, they tend to be sarcopenic, and therefore they have reduced muscle bulk or muscle masses. And if we do remember, if you have extremes of body weights or body sizes, you are actually not able to use eGFR estimation calculations properly. This is very important to realize that, to remember, because most times our dosing of chemotherapeutic agent is based on GFR or creatinine clearance. So if you don't get a precise GFR estimation, you may either be overdosing or underdosing patients. So it's very, very important to remember that you need to be able to assess the GFR properly in any patient with cancer. And this is actually a subject of debate. Should we be using cystatin C instead? Bearing in mind that the use of steroids in most patients with cancers may actually upregulate cystatin C and cause an error in estimation of GFR. Additionally, certain cancers may also cause cystatin C to be elevated, and therefore you may have errors in estimation of GFR. So the true or the best estimate for GFR in patients with cancer is quite a subject of debate, and we should look at all the patient characteristics to be able to determine what the optimal GFR is. And in certain cases, you may actually need to do isotopic GFR to be able to determine optimal or best values of GFR for your drug dosing. Again, patients with CKD tend to have higher risk of development of cancers, particularly patients with advanced CKD. And indeed, malignancies or cancers are major causes of mortality, second to cardiovascular disease amongst our patients with CKD. Again, patients with dialysis, particularly patients on dialysis for more than 10 years, tend to develop acquired cystic kidney diseases, and these have a higher risk of transformation into renal cell carcinomas. And we are all aware of the fact that patients who have kidney transplantation are at a higher risk of developing malignancies. First of all, from transformation of oncogenic viruses, as well as the inherent properties of some of the immunosuppressants that are given to such patients. Again, cancer survival is reduced in patients with CKD, and there's always a risk of acute kidney injury in cancer patients with CKD. It's therefore important to identify chronic kidney disease amongst patients with cancers, and therefore you can manage these risk factors accordingly. Certain cancers can have direct effects on the kidneys. For example, if you have malignancies like monoclonal gammopathy, particularly if linked to multiple myeloma, it may cause direct kidney damage. Additionally, certain solid tumors, breast cancers, lung cancers, may also cause a paraneoplastic phenomenon, resulting in the development of glomerular disease, most notably membranous nephropathy. Hematologic malignancies themselves predispose patients to developing paraneoplastic minimal change disease. It's very important to recognize these associations because it can actually guide our appropriate diagnosis and therapeutic strategies in these patients. In addition to cancer-related kidney disease, we have therapy-related kidney disease, and this is actually the focus of our presentation today. And as mentioned, we have traditional chemotherapeutic agents, new targeted agents, as well as immunotherapies. And several different variants of kidney disease have been associated with these therapeutic agents, spanning from glomerular and tubular injuries to immune-mediated injuries such as acute interstitial nephritis. So this figure actually shows the spectrum of kidney disease across the entire nephron, from the glomerulus all the way to the collecting duct. And you can see that at each portion of the nephron, you may have certain therapeutic agents causing particular kidney-related damage. The figure on B actually shows some of the electrolyte imbalances or abnormalities, which most often we get called for from nephrology. And they include things like hyponatremia, hypokalemia, hypophosphatemia. And these are usually multifactorial in origin. So I look at a few of the conventional cytotoxic agents. So this has already been mentioned with the various classes of the cytotoxic agents, spanning from antimetabolites such as gemcitabine, alkylating agents such as cyclophosphamide, and the platinum-based agents such as cisplatin. So this table actually summarizes some of the common cytotoxic agents that we use routinely. There are types of adverse kidney injuries and mechanisms, as well as preventive mechanisms or preventive strategies to prevent the development of kidney diseases. So platinum agents could include agents such as cisplatin, carboplatin, and oxaliplatin. I'll be touching a bit more on that briefly. Then you have cyclophosphamide, which is noted for causing hemorrhagic cystitis. A closely related agent, ifosfamide, because of its toxic metabolites, actually causes an AKI, in most cases an acute tubular necrosis. Then you have agents such as methotrexate, which has been associated with development of intratubular crystals. Then gemcitabine and some of the other medications resulting in the development of thrombotic microangiopathy and acute kidney injury. So with the platinum-based agents, carboplatin, cisplatin, and oxaliplatin. Cisplatin is the first generation, carbo second generation, and oxaliplatin is the third generation. And they would usually result in development of a dose-dependent non-oliguric AKI. So you don't evaluate the kidney function, you may miss it because the patient may still be passing good urine. So you would think that kidney function is good. So you should realize that they would usually result in a non-oliguric AKI, and most often it's from acute tubular necrosis. This usually occurs in up to 30% of the patients on cisplatin, particularly with higher doses, more than 60 milligrams per meter square in one cycle, or if the total cumulative dose exceeds 300 milligrams per meter square, then your risk of developing this dose-dependent acute tubular necrosis is actually higher. AKI risk is highest in cisplatin compared to carboplatin and oxaliplatin. So for patients who may be at risk of developing kidney disease, we may opt for second or third generation to minimize our risk for developing AKI in such patients as well. Generally, once you withdraw the medications, there's usually a resolution of ATN. However, there are a few patients who may actually develop to states where they may need dialysis for supportive therapy whilst there's recovery of the kidney function. So it's important to identify this because, like I said, they would still be passing urine. So if you don't monitor the kidney function, you may not be able to pick up this acute tubular necrosis, and therefore you may have worsening of a kidney function, eventually resulting in kidney failure. Besides acute kidney injury from acute tubular necrosis as described, you may have things like hypomagnesemia, a Fanconi syndrome, distal renal tubular acidosis, hyponatremia, as well as a thrombotic microangiopathy. And these have been well described with the use of a first generation, and that is the cisplatin, rarely with carboplatin or oxaliplatin. So that may be another reason why you probably would consider the newer generation platinum-based over the first generation ones. To further understand cisplatin nephrotoxicity, we'll use this diagram. And basically, this is the proximal tubule. And as you can see, there's an apical section where that's the urinary section, as well as, excuse me, yeah. So there's an apical section, that's the lumen, and there's a basolateral section. So generally, cisplatin causes toxicity in the proximal tubular cells. So what happens is that cisplatin is taken up into the proximal tubule by several families of transporters, including the organic cation transporters. And these are regulated by magnesium. So in cases of hypomagnesemia, you may actually have increased expression of these transporters, and therefore you have a larger dose of cisplatin within the proximal tubules. Accumulation of cisplatin in the proximal tubule, I would not bore us with all the processes, but eventually it results in mitochondrial toxicity, and that is what causes the acute tubular necrosis. So this actually provides an option for therapeutic targets in the management of prophylaxis against cisplatin toxicity. There's some limited data that supplementation with magnesium may actually counteract cisplatin nephrotoxicity. First of all, by preventing the uptake of cisplatin, as well as increasing the extrusion of cisplatin into the lumen. Again, there's proposed use of statins, forced diuresis with mannitol, as well as use of metformin, but these have actually produced conflicting results. So as present, we are actually looking at magnesium supplementation, albeit limited data, as well as hydration in the prevention of toxicity due to cisplatin. Again, as I mentioned, about 50% of patients who are given cisplatin develop some form of magnesium wasting. And this, as I said, would also compound the adverse effects of the cisplatin. And therefore, administration of magnesium may actually reverse or prevent the development of this toxicity. In terms of prevention of cisplatin or platinum-based agent nephrotoxicity, hydration has been proposed as a major way of preventing nephrotoxicity, and this dilutes the concentration of the medication and therefore reduces the risk. Magnesium supplementation, as I mentioned earlier on. There has been a proposed role of hemodialysis, but generally cisplatin is highly protein bound and therefore not amenable to dialysis, especially after 24 hours. We may use dialysis just as a supportive measure while the kidney recovers, but it doesn't address the cisplatin toxicity in itself. Then cyclophosphamide briefly. Cyclophosphamide is a commonly used agent in both autoimmune diseases as well as in cancers and for several other indications. Generally, it causes hemorrhagic cystitis, particularly when given in higher doses, and the prophylaxis is usually using Mesna as well as volume expansion before the use of cyclophosphamide. Again, it's important to realize that it's always very important to dose cyclophosphamide according to the GFR to reduce the potential of some of these toxicities that has been mentioned. Then gemcitabine, generally also a very common agent that is used for solid tumors generally may result in development of either a systemic TMA that is characterized by development of a full-blown microangiopathic hemolytic anemia, thrombocytopenia, proteinuria, as well as acute kidney injury. In certain cases, it may only result in kidney-limited TMA with AKI and proteinuria. This tends to occur in up to about 1.5% of patients who are given such therapy. Additionally, there may be development of hypertension, and the development of hypertension or new onset hypertension or worsening hypertension may actually indicate that the person may be developing toxicity from this agent. It is therefore very important that patients who are put on such therapy should have their blood pressures monitored and their urine monitored so that we can actually identify these toxicities early. And in most cases, stopping the agent often stabilizes or improves the kidney disease. There are certain situations where stopping the agent in themselves may not necessarily result in recovery, and you may need things like plasma exchange, particularly if there is some indication that there is some alternate complement pathway activation. And in such cases, beyond plasma exchange, you may use complement inhibitors such as eculizumab, and there have been successful trials with the use of this agent in patients with gemcitabine nephrotoxicity. However, the only drawback is that eculizumab is one of the most expensive drugs in the world, and so as you can imagine, that's not readily available to patients in our part of the world. Then methotrexate is an anti-dihydrofolate reductase inhibitor, and generally it's very active against cells that rapidly multiply. Remember that methotrexate is predominantly renally excreted. So for patients who have renal impairment, the drug tends to accumulate and increases the risk of both renal and extrarenal manifestations. Extrarenal manifestations may include things like mucositis, hepatitis, and even encephalopathy. When used in high doses, so-called high-dose intravenous methotrexate, usually in excesses of more than 0.5 grams per meter square, methotrexate causes vasoconstriction of the afferent arterioles, and most importantly, forms intratubular crystals, which may cause obstruction. And generally, this occurs when the urine is acidic or there is low urine flow, particularly in patients who are hypovolemic. Therefore, the treatment usually involves alkalinizing the urine, and this is usually achieved using alkaline containing crystalloids, usually starting 24 to 48 hours prior to the administration of high-dose methotrexate. The aim is to get a pH of above 7 and a urine output predominantly above 2.5 liters to reduce the risk of this crystallization within the tubules and therefore development of acute kidney injury. Leucovorin may also be administered within 18 to 48 hours of high-dose therapy to prevent the extrarenal and renal complications of that. But most importantly, the new recombinant bacterial enzyme, which is not available in our part of the world, would rapidly reduce the doses of methotrexate in cases of toxicity in less than 15 minutes, and this can minimize the adverse effects of the methotrexate. So remember that because of the inherent nephrotoxicity of methotrexate, you would need to avoid other concomitant medications that have the potential of causing acute kidney injury, such as NSAIDs, penicillins, and proton pump inhibitors. Additionally, these agents may actually interfere with the kidney's ability to excrete or eliminate methotrexate through urine, and therefore you may have increased toxicity from methotrexate in such cases. Then to the targeted therapy. This actually shows a list of the common targeted therapies that have been licensed by FDA, from the VEGF inhibitors or vascular endothelial growth factors inhibitors like bevacizumab. And anytime I come across some of these names, I'm so glad I'm no longer in medical school. I can just mention the class of the drug and skip these names that accompany these groups of medications. And basically, these are anti-angiogenic factors, and so therefore, if you inhibit the angiogenic factors, and so if you inhibit them, the endothelium, particularly in the kidneys, are disrupted, and that can result in several complications, including development of hypertension and TMA. Similar to that are the tyrosine kinase inhibitors. And I think the CDK inhibitors were also mentioned. What I want to mention about that is the fact that they actually cause a phenomenon called pseudo-AKI, where they compete with creatinine for secretion from the tubule. So because you preferentially secrete these medications compared to creatinine, you tend to have an elevated creatinine, and that seems to portray the picture of an acute kidney injury. So it's important to remember that once you put patients on such medications, you need to monitor. If creatinine goes up, you need to look for other causes. If there's no other causes, you probably attribute it to that, as long as there are no other manifestations of kidney injury, such as worsening hypertension and proteinuria. So briefly on the VEGF, the incidence of hypertension is up to about 30%. And like I said, because they are anti-angiogenic, you tend to have nitric oxide depletion within the endothelium, and that is what causes the vasoconstriction and therefore hypertension. In more extreme cases, there's salt and water retention, resulting in endothelin release and capillary contractions, and that can actually lead to endothelial damage and thrombotic microangiopathy, resulting in proteinuria, particularly if the podocytes are involved. Generally, the hypertension, it's mild, with very severe hypertension occurring in about 5% of the cases. In cases of mild hypertension, you would usually maintain the therapy, particularly if there's no proteinuria. And the first line of medication is usually the calcium channel blockers, or you may consider ACE or ARB as a second line. However, in patients with very severe hypertension, you may consider a temporary hold on these medications, and only a complete hold if the proteinuria persists or there is development of a thrombotic microangiopathy. Then in that case, you definitely need to stop the medication. Another thing to realize is that following completion of treatment with these agents, your BPs may drop to pre-treatment levels. And so if you give so much antihypertensives in the control of these, you definitely need to be monitoring such patients, because in most cases, the BPs may return to normal. If you don't identify this, patients may develop hypotensive episodes with all its attendant adverse effects. Then nephrotoxicities of the newer immunotherapies. Again, these are some of the approved immune checkpoint inhibitors. Ipilimumab, which is a CTLA-4. Then you have the program DEath1, PD-L1 agents as well. And in most cases, this will result in things like acute interstitial nephritis and then TMAs in certain cases. This actually shows the FDA approvals for the use of these in several different cancers spanning 2015 to 2030. And you can see that there's increasing indication for the use of these medications, and they have been shown to be beneficial in both early stages and late stages of malignancies. So briefly on those immunotherapies, for the immune checkpoint inhibitors, basically AKI, acute kidney injury, is the most common immune-related effect, and it usually manifests as an acute interstitial nephritis. In certain cases, it may provoke a glomerular disease or glomerular nephritis, such as FSGS, membranous nephropathy, and even lupus nephritis, and these have been well described. It's also important to remember that besides the acute interstitial nephritis, you may have things like nephrotic syndrome, as well as some electrolyte derangements as part of a distal renal tubular acidosis. Usually, risk factors for development of acute interstitial nephritis from these agents would include concurrent use of other medications that can potentially cause interstitial nephritis, and this would include things like NSAIDs and PPIs, as well as an initial low baseline eGFR. And in certain cases, combination of these agents may actually also increase the risk of acute interstitial nephritis. Then there's a CAR T cell, which is actually coming up so much in terms of treatment, chimeric antigen receptor T cell therapy. And it's actually being used in several different malignancies in recent times. The only drawback is the development of a cytokine release syndrome as well as a macrophage activation syndrome. And these have potentials of causing acute tubular injury when you use this. And there are reports of up to 20% risk of developing acute kidney injury with the use of these agents, mostly within the first week of you initiating therapy with these agents. The good thing about it is that majority of these are mild AKIs or early stage AKI, and there's actually a rapid recovery, usually within the first 4 weeks post-treatment. So that's a good thing, considering the fact that they are growing in importance as an effective therapy for a lot of cancers. Then, of course, the pro-inflammatory cytokines, which have also been associated with the development of acute tubular injury. So there are reports really of the fact that acute kidney injury tends to occur in the use of the checkpoint inhibitors. And this development of acute kidney injury has been noted as a significant risk factor for mortality in patients with oncological conditions. So this schema actually looks at our approach to management of any patient who is put on an immune checkpoint inhibitor and develops acute kidney injury. It's always very important, as we mentioned, that it's usually due to acute interstitial nephritis. So you need to find out, is the nephrotoxicity due to other causes like PPIs or NSAIDs? If it is that, you need to stop those medications and continue your ICIs. But generally, once you develop an interstitial nephritis, you need to stop all the medications and start in your investigations. If there is evidence that this is due to the immune checkpoint inhibitor, particularly if there's a lot of proteinuria, hematuria, and high-grade granular cast and renal tubular acidosis, which we said was a manifestation of these conditions, you may consider a kidney biopsy to confirm whether this is probably acute interstitial nephritis from these agents. And in most cases, withdrawal of these medications or switching to a different class, as well as concomitant use of steroids, may help in resolution of these medications. The good thing is that the outcomes are usually good following identification, appropriate management, including cessation or switching of classes and the use of steroids. As many as 71% of the patients would recover back to their normal baseline before the development of acute kidney injury, or within the 25% of their baseline. 14% of them may develop partial recovery. So as many as 90% plus may actually recover. And the recurrence rates are usually up to about 25% following re-challenge with these agents. So it's always very important to look at the risk versus benefits of these agents vis-a-vis development of these toxicities, as well as cure of the cancers or malignancy. So I'll put all this together by looking at various strategies that we can use to prevent chemonephrotoxicity. Most importantly, I'll look at the drug dosing. It's always very important that we adjust the doses, and most of these medications, we actually need to dose. Adjust. Dosing is not recommended for most of these when the GFR is less than 30, and it's always very important to look at the risk versus benefit. For example, if you consider cisplatin, generally you can give a full dose if a GFR is above 60, but once it goes less than 60, you may either consider an alternate agent or do a 25% dose reduction. And this is very important to reduce the nephrotoxicity as well as other adverse effects that we may be considering. And generally, it's important that once you put patients on these medications, particularly those that are inherently nephrotoxic, it's very important that we do regular checkup. Not only look at reduced urine volume to tell that a person has developed an acute kidney injury, but we need to be monitoring their kidney function, their blood pressures because of the development of hypertension, a few of them, as well as their urine, looking out for blood proteins and other markers that may suggest an increase in development of these conditions. Also important is volume expansion, which has been established as one of the prophylactic measures in the use of most of these agents. It's very important to initiate this within 24-48 hours of the use of these medications. And this has actually been shown to reduce the risk of development of nephrotoxicity from that. The role of magnesium supplementation has been described, and it may have a role in reducing cisplatin nephrotoxicity. And generally, there has to be adequate nutrition, other supportive management, As much as possible, try and avoid NSAIDs because of the compounding effects of NSAID in development of acute kidney injury in patients taking some of these medications. Additionally, because patients may have other comorbid conditions, which are also themselves risk factors for development of kidney disease, such as diabetes and hypertension, it's very important to address this. And management of these conditions, diabetes or hypertension, may actually reduce a person's risk of developing an AKI or possibly progression of their chronic kidney disease. It's important to always remember that management of such patients should actually involve several disciplines. And generally, we get referrals in nephrology. Once there's a development of a therapy-related injury, then we get patients coming in. So the discussion should always be between the two managing specialties. Should we continue the medication or not? Should we look at the patient state? What is our therapeutic goal? Should we just add on steroids or switch totally? Is there a need for biopsy? In cases of immune checkpoint inhibitor therapy, should we restart a different class? What should we do? By the end of the day, teamwork should be important, and the goal is to improve patients' outcomes. So I'll conclude by stating that nephrotoxicity is quite common in many anti-cancer agents and can actually be a limiting factor in cancer treatment, because once you develop AKI, you tend to think that, hey, let's withhold the medication. There's no other alternative. And that actually causes adverse effects of the cancers themselves. It's very important to closely monitor the renal function, blood pressure, urine, and then promptly address any issue that may have resulted or any cause that may have resulted in that. And once you treat that, there's actually a higher risk of protecting the kidneys. It's very important to understand that drug dosing bulletins are available, and so it's always necessary to look up those medications that you are given, look at the possible adjustments. Are we assessing the kidney function appropriately? Nephrology is always available to discuss these things so that we can actually improve the outcomes amongst our patients. Thank you very much for your attention.
Thank you very much, Dr. Inusa. It's been an excellent lecture. I'm actually overwhelmed with the new information that the two presenters have provided this afternoon. And also there's a frightening aspect that 50% of all new cases present with metastatic disease. And our mortality still stands at 50%. We also realize that it appears that the investigations and the management of metastatic breast cancer come with huge costs. And I'm wondering how those in low resource centers can be helped. Then we have a catch-22 situation with the treatment as far as kidney function is concerned. Where do we draw the line? These are some of the things passing through my mind, but I believe that most of the participants have more questions and maybe suggestions to offer. So I will ask Dr. Amu to help us with the questions and answer session. Thank you very much once again, Dr. Annie and Dr. Inusa. I'm sure you are available to answer all the questions.
Thank you very much, Dr. Hansen. So I'm going through the chats. I think some of the questions have been answered. Let's see. Okay, so I think there's a question for Dr. Inusa. Which antihypertensive medications are recommended in hypertension induced by cancer treatments?
Okay, thanks so much for the question. So, as I mentioned, depending on the mechanism of action of the hypertension, you may actually have, for example, with the VEGF inhibitors, it's more vasoconstriction because there's consumption of the nitric oxide. And so therefore, calcium channel blockers are probably the first choice in management of that. Of course, once proteinuria develops, then you may consider the use of agents such as ACE inhibitors or ARBs. So there's definitely the key role or first-line use of calcium channel blockers, but this should be individualized according to the patient's characteristics.
Okay, there is a question from Uduak Abasi. It says, thank you, Dr. Annie, very enlightening presentation. Please, are the newer agents and the specific tests you mentioned available in the country? Is the treatment entirely borne by the patient?
All right, thank you very much. Yes, Gordon. Yes, thanks for the presentation, for the question. You know, some of the agents are available in the country. For instance, a number of the targeted agents I mentioned are available. For instance, trastuzumab, pertuzumab, they are available. The Herceptin, that is trastuzumab, has been taken up by the government on the national health insurance. So that is for 1 year. They have free Herceptin medication. And usually that is the period that you take it in the adjuvant setting when you have early stage disease and we are treating it purportedly to cure the disease. You take it for 1 year. That has been taken up by the government, is free. Before 2019, only about 3% of patients from a study that I did were able to afford Herceptin. 3%. But after 2019, anecdotally, about 100% of patients are now on Herceptin. Pertuzumab is not on the national health insurance, so you have to pay for the drug. The agents like palbociclib and that is the CD4K6 inhibitors, those ones, the cyclin-dependent one, those that inhibit them in the cell cycle. For those medications, there's, for instance, Pfizer, a pharmaceutical company, has brought in an access program. And with that access program, they reduce the medications significantly for sub-Saharan, African countries or low middle income countries. Such that, if you're buying the medication in developed countries, it will be much more expensive than you get it here. Even then, something like palbociclib could be going for 3,000 Ghana cedis, maybe for a cycle, and that is significantly reduced, or maybe a little less, 2,000 to 3,000. Even then, it is almost impossible for some patients to afford. The other medications like the mTOR one, the everolimus, it can be available. In some cases, it is. What happens is, even when the drug is not readily available, usually with the pharmacists, we can write through FDA and bring in the drug into the country for the patients. The immunotherapy agents are available. Roche has atezolizumab and pembrolizumab from MSD. It's available in the country. They are just expensive. So patients have to pay. So you have patients paying between 5,000 to 10,000 to 20, even to 40,000 Ghana cedis, probably a month or so. Some of them have, for instance, they have insurance like enterprise insurance. There's this sort of insurance package for them. So you buy one, you get one free or something like that. The various access programs, but it's generally very expensive. And there are a few of them which are not available, but can always be procured if you write through FDA for them. Thank you.
Thank you. Dr. Inusa, someone wants to find out what are some of the examples of the alkaline-containing crystalloids?
Okay, thanks so much. So basically, the commonest would have available would be the Ringer's lactate. So any fluid with acetate, lactate, any of those can will eventually be metabolized in the liver to bicarbonate. So plasmalite, Ringer's lactate would do in terms of alkalinizing the urine. But in certain cases, if your pH in the urine is very low, you may actually give things like potassium citrate. All that would result in alkalinization of the urine to reduce the methotrexate tubular crystallization.
All right, Dr. Nusa, so there are further questions for you. How do we manage patients who develop renal dysfunction mid-treatment? Do we pause, do we reduce the dose, or do we switch drugs? And then there's also another question that is asking, what are the common signs of acute kidney injury during chemotherapy that frontline providers should look out for? So if you can take these two questions together.
Okay. So how do we manage patients who develop renal dysfunction mid-treatment? Do we pause, stop? And so I'll be honest with you, from the nephrology point of view, in most situations, we are only worried about the kidneys. So that's an honest truth. So we'll just write back to oncology, hey, the drug caused this, stop it. But I think it should be a shared decision where we discuss with the oncologist and everybody else involved in the patient management, as well as the patient themselves. Are there alternatives? If we are really sure the drug is the cause of the dysfunction, of course, any patient with cancer may develop AKI from any reason. Could have been a gastroenteritis that the patient developed that caused an acute kidney injury. So once those are ruled out and we think that the medication is the cause of that, then we need to have a discussion, all the teams involved. Are there alternatives that we can use to salvage the kidney function, or do we persist? So this is not a yes or no answer, or not one fits all. We need to have a decision making, more like a multidisciplinary team approach to discussing that. Like in the cases of immune checkpoint inhibitors, if you identify that this is it, you may switch a different class with the use of steroids, and sometimes they may not have a recurrence of the disease. So it has to be on a patient case-by-case basis. Then in terms of common signs of acute kidney injury, I must say that in a majority of the cases, if you actually look at the definition of acute kidney injury, it is either an increase in the serum creatinine and or a reduction in the urine output up to a certain threshold. So we are always misled when we have patients who take certain medications such as cyclophosphamide, or they take things like cisplatin and they develop acute kidney injury. They're still passing urine. And so if you haven't checked your kidney function, you would not know. So to a large extent, early on, you may not pick up any signs per se. The times that you may pick up signs is when the person is obviously in kidney failure with the uremic symptoms and vomiting and very acidotic. And that's really not the time you want to pick up. Any small increases in creatinine, it's very important to realize and try to reverse. So once you know that the patient is on some of these medications that have the potential of causing nephrotoxicity, even if they started with a normal kidney function, there's always a duty of care to repeat the kidney function at periodic intervals, pre-therapy, post-therapy, before the next therapy, post-therapy, so that any deviations from the normal kidney function can be addressed appropriately. Sometimes it's just about dehydration. Other times it's just because the person has some infection. So we need to look at that in that guide. If you don't test, you may not be able to find out any derangements of kidney injury.
Okay, so Dr. Enosa, there is another question. Someone wants to find out if there are specific thresholds for those adjustments in patients with borderline renal function.
Yeah, so very, very good question. So basically, for most of these drugs, they are renally cleared. Like I said, with methotrexate, 80 to 90% renally cleared. And of course, we have drug bulletins, BNFs, that actually will tell you what kind of dose adjustments, at what level shouldn't you give. And I did give an example of a drug like cisplatin, where if a GFR is below 30, you totally probably not give. If it's less than 60, you may do a 25 dose adjustment. So I always tell people that the nephrologist doesn't have all the dose adjustments of all the medications. And indeed, a lot of the medications that Dr. Ali mentioned, I have never seen them in use. I only get reports that, hey, this patient is on this medication and that has developed, and then we put our heads around it. So it's always very important that all those involved in this space should check up the drugs, the pharmacokinetics, dynamics, and then those adjustments before we actually give these medications. So this will be drug specific when it comes to drug dosing, yes.
And then there are two more questions for you. One is, what is your take on the use of cystatin C as compared to creatinine in the management of renal impairment? Then the last one is, how often should the kidney function be checked when on treatment?
Okay. So with the use of cystatin C, as has been published in literature, so cystatin C, it's a protein that is produced, it's filtered, and it's absorbed by the tubules and catabolized. So you don't get it coming out in urine. And basically, once there's an AKI, any small derangement of kidney function will cause the cystatin C to go up. And that's why most people would think that it's probably a better marker of early kidney dysfunction than creatinine. As I mentioned, creatinine is based on muscle bulk. And so for people who are very muscular, they may be having higher creatinine values. And so therefore, if you were to estimate their GFR, you get low GFRs. And for people who are very skinny, not muscular like myself, you tend to have lower creatinines. And so you may have an eGFR that is higher than it's supposed to be. So basically, in terms of using creatinine for the creatinine-based estimating equations, it is said that for people at extremes of body weight, amputees, people with malignancies who are sarcopenic and cachectic, where the muscle bulk is low, people who are very elderly, muscle bulk is low, you may be having very low creatinine levels. And so if you calculate the GFR, it's going to be very high, and that gives you a false impression. So there's a need to always look at the patient in totality. Cystatin C may be used, but the drawback is that in a lot of these malignancies, we do give them steroids. And so if you give someone steroids, the cystatin C is upregulated, and it's going to be high, and so you would get a GFR that is low. It doesn't mean that the person has a kidney impairment. Additionally, certain malignancies by their inherent nature, because of certain phenomena, including inflammation, cause an regulation of cystatin C. So it may have high cystatin C, but it doesn't necessarily mean that the person has that. So if there's any conflict as to how to get an appropriate GFR or kidney function for any patient, particularly at borderline levels where you're saying this is just borderline, is it true or not? Then you have the gold standards or a more specific or more accurate measurement, such as the use of isotopic GFR, which is readily available. And that usually can give you a true GFR for the patient to avoid either underdosing or overdosing. And I think that's how kidney function be checked on treatment. So for now, kidney function is checked using the serum creatinine, right? So you would measure your serum creatinine, estimate the GFR, bearing in mind that there are nuances in the estimation of GFR in patients with malignancies. Additionally, because of the other effects of the potential medications you are having, such as things that will cause proximal tubular dysfunction or Fanconi syndrome, you want to be checking your magnesium levels, your potassium levels, and all that. And those can actually give you an idea that there's a tubular damage going. But in terms of a kidney function, the overall best measure is the GFR. And in clinical practice, we use the eGFR. Additionally, looking at your urine, looking for blood, looking for proteins, all these can suggest that there's something going on in the urine, particularly if you're developing nephrotic range proteinuria. In terms of how often, it should depend on what the patient is taking, how often the patient is taking it, what is the baseline GFR. For people with more advanced kidney function, you may be checking the kidney function more frequently. For people who are taking more drugs that have been described as nephrotoxic, you may be checking these medications more frequently. But one rule of thumb is that for any medication that has potentially nephrotoxic effect, I would want to always check my kidney function before I administer. So once your kidney function is normal, for any patient that you started chemo with whose GFR say was 80, don't assume that the GFR may remain 80. You give cisplatin and you continue giving cisplatin without checking. You may actually end up with very bad kidney failure. So it's very important post-dosing, depending on the patient characteristics, and pre-dosing. Thank you.
Thank you very much. So I think a lot of questions that went to Dr. Hannah Ayite she's answered them already in the chat. And we had about 22 questions, and all of them have been answered. Dr. Hansen, I'm handing over back to you.
Yes, thank you very much. Dr. Annie, I'm very interested in
Yes.
the rollout of oncology services in the rest of the country, apart from Kumasi and Korle Bu. Can you tell us a bit more about it? Because I'm sure primary caregivers in the regions and so on and so in the districts will feel very uncomfortable listening to you what is required actually to even make a diagnosis and the management and the complications and how to handle them. So can you give us an idea about what is happening outside Kumasi and Accra?
Okay. All right. So thank you very much. So first of all, there are 3 oncology centers in the country. 2 are based in Accra, as we know, at the Korle Bu Teaching Hospital, which is a private center, and then the Sweden Ghana Medical Center, which is private. And then we have the 3rd one, Konfanochi Teaching Hospital, the Radiotherapy Oncology Center there. So in the Northern Belt, we don't have any radiotherapy center as yet. But these are 3 radiotherapy, that is, we do both radiation and medical oncology services. But there are other satellite clinics which are coming up in some other parts of the country. So for instance, the Cape Coast Teaching Hospital, there's a small oncology clinic coming up. So colleagues from our center go there and see the patients, have tumor board, that is multidisciplinary tumor board meetings, discuss where the patients need simple chemotherapies that can be given there. The nurses are being trained there to do that. And where they need to come for radiotherapy, they come to Accra. Whole Teaching Hospital as well is also starting something like that. Even at the International Maritime Hospital, there's also a small chemotherapy satellite clinic there as well. So we are having a Tamale Teaching Hospital as well. We have a trained medical oncologist who also manages that. So you realize that it's gradually picking up in these centers. I know the government has plans to increase the number of radiotherapy centers in the country so that some of these other smaller satellite clinics will now become a full comprehensive cancer centers. Another thing that the Ghana College, together with the Ghana Medical Association and Roche Pharmaceutical company, that includes myself and faculty chair for Prof. Wuku for internal medicine, is that we have started collaboration some time ago, and now we have 2 internal medicine physicians training in Kenya for pure medical oncology, and 2 more who will be joining them. So hopefully we'll have 4, and it's supposed to be a train-the-trainer program in the Ghana College. So they will come back after the 2-year training in medical oncology with internal medicine entry, come back and be medical oncologists in the country and train others. We are also, for the clinical oncologist trained like myself here, we are trained both as radiation and medical oncologists. But with the widening, the fact that medical oncology training is becoming, very subspecialized, the drugs are increasing in number and all of that, at a certain point, it may become almost impossible for a doctor to both do full radiotherapy and clinical and medical oncology. So we'll still continue with the program, the clinical oncology program, radiation and medical, and at the same time, this medical oncology training has also started. So once they come back, they also continue and train more medical oncologists, because oncology is such that not every patient requires radiotherapy. Some may just need the systemic chemotherapy agents. That means that if you are in O and there's a medical oncologist there, you can have the training, you can have the treatment there, and you may not need to move to a radiotherapy center. Even if you do need at some point, you can have your chemotherapy and then move to the existing radiotherapy center. So that's sort of a short to medium term resolution of the problem. But in the long term, we need to have radiation centers at least in every region within the country. The other thing is the Ghana Health Service has some designations for what the center, for instance, at a CHIPS compound, all you can do is identify, screen for cancer, and then move on to the health center. And then from there to the district hospital. So there are some things the district hospital can do, maybe some mild biopsy or some minor tests. Then at the regional hospital, you can have further imaging, CT scan, MRI, depending on what is available. But for treatment, you have to be in the teaching hospital. That is the Kolebu Teaching Hospital or the Konfanochi Teaching Hospital or the Sweden Ghana Medical Center. I hope that answers the question.
Well, yes, but I'm still uncomfortable because the majority of our people will not be able to.
Yes, no. So
treatment.
Yes,
it's not your fault. It's not your fault, but it's just the nature of the
that's
economy.
True. The logistics, transportation issue. There are patients who are also even so afraid of Kolebu. Immediately you mention they have to go to Kolebu, they think that is a death sentence. So then they don't even want to come. So the referral system is something we are trying to talk more about, and then patient navigation. So this is also something the government is also looking into, so that with time, once you have the patient navigators, either the nurse navigators or survivors who have gone to the treatment to help navigate these patients, because we noticed that research has shown that with patient navigators in the system, it improves the adherence to treatment and patients actually completing their treatment. And then another thing, finally, I want to mention is a multidisciplinary tumor board. You know, we've started, virtual meetings. So it's possible for a doctor in 37 military hospital or police teaching, or even in a regional hospital, to join some tumor board meeting to discuss their patients and decide on what kind of management is appropriate for them. So this is something that if it becomes more widespread, then you can be far away, but at least you have an idea of what kind of referral system is available for your patients. Thank you.
Thank you. Thank you very much. So knowing these complicated treatment schedules and investigations, it is very important for all of us to try as much as possible to catch them early.
Yes.
So that we reduce the number of patients who present with advanced breast cancer.
Yes.
So that's the take-home message for all of us. And then, Dr. Inusa, thank you very much. We realized that when Dr. Ani and her colleagues bring the patients back to us, we should be looking out for complications, especially the renal ones, so that we can alert the nephrologists as soon as we detect them. So on this note, I want to thank all of us, especially the presenters, for our patience. We've been here for 2 hours, and it's my prayer that it's not been a wasted time, but it will bear fruit in the future as far as breast cancer management is concerned. Thank you very much.
Thank you.
Yes, I will hand you over to Dr. Amo.
Yes, thank you very much, Dr. Hansen, for the excellent moderation. And we also want to say a very big thank you to the presenters. Just like last week, this session has also been a very excellent presentation. And we are very grateful for the detailed delivery. And we are also very grateful to all the participants who were able to join this session today. And once again, we exceeded our capacity, and we had to stream on YouTube. So this is something that we are happy about in terms of building capacity of healthcare professionals when it comes to breast cancer diagnosis and management. So thank you all for joining, and being part of this movement. And until we meet again, I'll say stay safe, let's stay connected, and let's keep pushing forward together in terms of breast cancer early detection and management. Thank you very much, and enjoy the rest of your evening.
Thank you too. Good night, everyone.
Thank you very much.